Greetings from Indian Journal of Anaesthesia. I, Dr. Iniki Sharma, will be presenting an article published in the March 2025 issue of the Indian Journal of Anaesthesia. It is titled Comparison between opioid-based anesthesia technique and opioid-free anesthesia technique in patients undergoing laparotomy for gynecological malignancy, a randomized controlled trial. Opioid-free anesthesia eliminates systemic neuraxial or intracavitary opioids, reducing side effects like respiratory depression, PONV, sedation, and delayed discharge. Opioid-free anesthesia strategies incorporate regional anesthesia, TIVA, and adjunct agents such as alpha-2 agonist, ketamine, lignocaine, and magnesium. Gynecological cancer surgeries require effective pain management for early mobilization, patient comfort, and reduced hospital stays. OFA has been studied in bariatric breast cancers and gynecological laparoscopic surgery, showing better recovery profiles and reduced opioid-related side effects. So this study aims to find out whether opioid-free anesthesia technique versus opioid-based anesthesia technique in gynecological, oncological laparotomies, focusing on early recovery and opioid-related side effects. So the primary outcome was the time to attain post-anesthesia care unit discharge criteria, and the secondary objectives were time to eye-opening, extubation, PACU transfer, VAS pain scores, time to first analgesic request, QOR 15 scores at 12 and 24 hours, post-operative analgesic use, and PONV incidence over 24 hours between the two groups. So institutional ethical committee approval was taken and trial was registered in CTRI. Patients included were ASA grade 1 to 2 with 18 to 65 years of age undergoing elective open gynecological surgeries under general anesthesia. Allergies to medications used in study, contraindication to regional anesthesia, long-term analgesic reliance and opioid tolerance, and patients with existing chronic pain, epilepsy, and mental health disease were excluded from the study. A written informed consent was obtained and they were divided into two groups by computer-generated random number table, and allocation concealment was done by sequentially numbered opaque sealed envelopes. So there were two groups. In group OBA, that was opioid-based anesthesia, both the groups were given analgesia by a blinded investigator, and it was in OBA, saline was used for infusion analgesic. For induction, 2 mics per kg of fentanyl was used, and for maintenance, fentanyl 0.5 mics per kg per ml was used. In the OFA group, dexmedetomidine 50 ml loaded in a 50 ml syringe was used for infusion and induction. For the primary analgesic, ketamine 0.25 mics per kg was given, and for maintenance, ketamine 0.15 milligram per kg per ml was given. And if the rescue analgesic, if more than 3 maintenance analgesic was required in 1 hour, then fentanyl 0.5 mics per kg bolus was given in both the groups. Both groups received bilateral rectus sheath block. In group opioid-based anesthesia, endotracheal intubation was done after with oxygen, air, isoflurane, and a BIS of 40 to 60, whereas in group OFA-based, after dexmedetomidine bolus and giving propofol, endotracheal and muscle relaxant, endotracheal intubation was done. Both group received IV dexamethasone 0.1 milligram per kg, PCM 1 gram, and ketorolac 30 milligram. MSET 4 milligram was given 30 minutes before skin closure. And in the PACO, if VAS score was more than 3, IV morphine 3 milligram was given, after which till first request for pain relief, nothing was given. And after the first request for pain relief, it was connected to a PCA pump with 1 milligram bolus, 5-minute of lockout interval, maximum limit of 30 milligram in 4 hours, and the patients were transferred from PACU to ward once the modified LRH score was more than 9. So the primary outcome was time to attain the PACU discharge criteria. Secondary outcomes were time to eye opening, extubation, PACU transfer, VAS pain scores, time to first analgesic request, QOR 15 at 12 and 24 hours, post-operative analgesic use, and incidence of PONV. Sample size was based on a previous study at 90% power and alpha of 0.05, 22 per group. Taking 15% dropout, it came out to be 25 per group. So this is the consort flow chart. And this is the table showing the baseline characteristics between the two groups, which is similar. Coming to the primary outcome, which is time to attain the PACU discharge criteria, it was similar between the two groups, whereas the time to extubation was significantly longer in the opioid-free group. So we can see that the primary outcome, that is time to attain the PACU discharge criteria, was similar in both the groups. The secondary outcomes, time to eye opening, eye opening was similar, whereas time to extubation and time to shifting the patient to the PACU was significantly longer in case of the opioid-free anesthesia group. Rest of the parameters were similar in both the groups. QOR 15, we had to take individual parameters because of the presence of urinary catheter required in these type of surgeries. So except two parameters at QOR at 12 hours, the rest of the parameters did not differ significantly between the two groups. Even those which came out to be significant, clinically this was not significant. So the time to meet PACU discharge criteria was similar between the two groups, which is consistent with previous studies. Some meta-analysis reported longer PACU stay in OFA due to varied anesthetic regimen use. Extubation and transfer to PACU was delayed in OFA group, which is similar to previous studies. This can be because of the use of dexmedetomidine. The first analgesic request time and total morphine use over 24 hours were similar, possibly due to use of rectus sheath block in both the groups. There was no significant difference in PONV, likely due to the use of volatile anesthetics in both groups. The study strengths include a double-blinded randomized design, PACU discharge criteria as a primary outcome, and the inclusion of rectus sheath block in both groups. OFA showed potential benefits even in complex open abdominal surgery, reinforcing the role of multimodal analgesia. Surgical heterogeneity and delayed urinary catheter removal may have influenced recovery time and QOR 15 score interpretation. So the technique of OFA using IV dexmedetomidine, ketamine, and ultrasound-guided rectus sheath block achieved a comparable time to meet the PACU discharge criteria when compared with the opioid-based anesthesia technique in adult patients receiving GA for open gynecological oncological surgery. Thank you.